Hello, everyone, and welcome to today's program titled X-linked Hypophosphatemia and Tumor-Induced Osteomalacia, focused on novel treatment options. I'm Carl Insogna, professor of medicine at the Yale School of Medicine. I direct the Yale Bone Center there, and I'm associate director of the Center for X-linked Hypophosphatemia in New Haven, Connecticut. I'm joined today by my colleague, Dr. Jill Simmons, who's a professor of pediatrics in the Pediatric Endocrinology and Metabolism section at Vanderbilt University. She also directs the Pediatric Metabolic Bone Disease Program there in Nashville. Dr. Simmons and I are investigators for and have received honoraria from Ultragenics. I've also received funding for an investigator-initiated grant. The disclosures for the other people who helped put this program together are listed. This program is provided by the North American Center for Continuing Medical Education and is supported by an educational grant from Ultragenics. Please remember to complete the test at the end of this presentation. This slide just summarizes necessary information because this is a continuing medical education program. The learning objectives of this program are to describe the pathophysiology of these two disorders, to tell you about the mechanisms and the treatment benefits and risks associated with the treatment of these disorders, to help you personalize strategies for the long-term management of patients with these diseases, as well as to alert you to the other disciplines that can help you in caring for these patients. So we're going to start with an overview of phosphate homeostasis, talk about the incidence and prevalence of XLH and TIO, talk about the pathogenesis and clinical manifestations of these disorders, and then turn to the safety and efficacy of treatments for both children and adults with both XLH and TIO, and end with what remain to be addressed treatment challenges in these chronic disorders. So the two major hormonal regulators of extracellular phosphate are PTH and FGF23. PTH, principal raison d'etre, is to defend against hypocalcemia, and does so in part by lowering serum phosphate, but of course, as you know, it also raises serum calcium. It lowers serum phosphate by inducing renal phosphate wasting. However, as part of its mechanism to defend against hypocalcemia, it increases production of 1,25-dihydroxyvitamin D, which increases both calcium and phosphate absorption from the gut. As you know, the parathyroid glands are located behind the thyroid gland. There are 4 of them. FGF23 principally defends against hyperphosphatemia. It has a relatively slower onset of action compared to PTH. It's produced by osteocytes. These are cells embedded in bone that have the unique ability to sense the extracellular phosphate concentration. And when they do so, they release FGF23. Osteocytes, of course, are also critically important for controlling the action of osteoclasts and osteoblasts. They're mechanosensing cells. But for our purposes today, the important function they have is to detect rises in the extracellular phosphate and release FGF23, which acts in the proximal renal tubule to cause renal phosphate wasting. Unlike PTH, it lowers 1,25-dihydroxyvitamin D levels by increasing the catabolism of 1,25-dihydroxyvitamin D, which leads to impaired phosphate absorption from the gut. So not only do you get renal phosphate wasting, but you get impaired phosphate absorption from the gut. The incidence and prevalence of XLH and TIO are summarized here. They are rare but instructive musculoskeletal syndromes because they highlight the critical importance of phosphate in skeletal homeostasis. XLH is caused by a mutation of a gene on the X chromosome called PEX or PEX, depending on how you pronounce it. Its prevalence is not known with certainty. Its estimates range from 1 to 50,000 to 1 to 20,000. TIO is an acquired paraneoplastic syndrome. Its prevalence is not known. It's extremely rare. I see a patient with this syndrome once every few years. One of the problems in diagnosing these disorders in the United States, at least, is that we no longer routinely measure phosphate. Combined with the fact that they are rare disorders and can present with nonspecific syndromes, often leads to long delays in diagnosis. So now we're going to talk about the pathogenesis and clinical manifestations of these two disorders. And Dr. Simmons is going to begin by describing this, the pathogenesis of XLH, and then talk about management in children. Jill?
Thank you, Dr. Insogna. So as was mentioned briefly in the prior slides, the primary problem in XLH is an increased amount of FGF23, which is produced by the osteocytes in the context of a patient who has a mutation in the PHEX gene. This increase in FGF23 is inappropriate and unfortunately leads to a decrease in the sodium phosphate symporters, which leads ultimately to an increase in phosphate excretion. This leads to a decrease in the serum phosphorus levels. It also leads to a decrease in the production of 1,25-hydroxyvitamin D and additionally an increase in the catabolism of 1,25-hydroxyvitamin D, both of which ultimately lead to a decrease of phosphate absorption at the level of the gut. So ultimately, a low serum phosphorus then can lead to impaired skeletal mineralization, which is certainly the hallmark of this disorder. In terms of clinical presentation, the primary abnormalities in children, at least, are skeletal manifestations. And you can see here that there are a variety of manifestations, including short stature, which of course affects the patient throughout lifespan. Most patients have significant lower extremity deformities in the form of bowing and windswept deformities. If bone biopsies are performed, we'll see osteomalacia due to the decreased mineralization in the osteoid. Patients often complain of bone pain, particularly in the lower extremities, and most significantly on days that they may have been more active than other days. And they also complain of muscle pain and muscle weakness, which in children can be manifested as hypotonia or delayed motor milestones. But sort of the hallmark in children in XLH is rachitic findings. Patients may also have cranial abnormalities, including Chiari malformation and craniosynostosis. They often have dental abnormalities, including tooth abscesses and excessive dental caries. And due to these abnormalities, they ultimately may have functional limitations and diminished mobility, such as delayed walking and significant gait abnormalities. There's a recent report published of 90 families of children with XLH, almost all of whom had been treated with conventional therapy with phosphate supplementation and activated vitamin D. And you can see here that there's a substantial number of patients with morbidity related to this disorder, including 80% reporting short stature, 72% reporting bowing of the tibia and fibula, 63% reporting bowing of the femur, and you can see here that surgery was required in a relatively alarming number of children with XLH. These same families also reported abnormal gait and joint and bone pain in a substantial number of children, and even 10% of these pediatric patients required a walking device. So what's the genetic basis for XLH? Well, remember that this is X-linked, but it is X-linked dominant. Mutations typically are missense, nonsense, deletions, or insertions in the PHEX gene, which is located again on chromosome X at this location. But recently, we've noted that 15 to 20% of patients may not have coding sequence mutations, and these non-coding region mutations may be significant. And most commonly reported is the 3 untranslated region, which is upstream of the polyadenylation signal effects. This has been reported to result in less severe phenotype, particularly in females, but there's still quite a bit we don't know about this particular mutation. Many patients with this mutation have been and likely should be treated to prevent the XLH phenotype. But the key point here is that molecular diagnosis should include evaluation of the untranslated regions of the PHEX gene, which is not always done in commercial labs. And of course, in any genetic disorder, family history is important. But remember that approximately a third of the cases in this particular disorder are spontaneous mutations. In terms of biochemical findings, the primary findings that we find are low phosphate levels and low tubular resorption of phosphorus. And you'll see here in the table, of course, we would expect a low serum phosphorus. It's important to obtain that while fasting because a recent meal may inadvertently increase that serum phosphorus level. TMP over GFR will be low. This demonstrates that there's phosphorus loss inappropriately at the level of the kidneys. 1,25-hydroxyvitamin D may be low, or it may be inappropriately normal in the context of hypophosphatemia. Alkaline phosphatase, which of course is a marker of bone formation and rapid bone turnover, will be elevated in these children. Serum calcium, if patients are not treated, is likely to be normal. Parathyroid hormone should be normal, except in the context of patients who've been previously on treatment, in which case it may be inappropriately elevated due to the treatment and not necessarily the disease process itself. And FGF23 now can be measured in commercial laboratories, and if measured, it may be elevated, but certainly it may be inappropriately normal. And this has been a problem for me clinically because some insurance companies have required an elevated FGF23, and we sometimes have to demonstrate to them that it's not necessarily that they're always elevated, but they're inappropriately normal in the context of hypophosphatemia. So how do we measure tubular reabsorption of phosphate? You need to measure the urine, phosphorus, and creatinine at the same time as the serum. And then you can calculate the TMP over GFR as is listed here. The way I think about this is the TMP GFR is the renal phosphate threshold. It's the threshold at which phosphorus begins to be excreted. And it's key that you use normative values specific for age. In pediatric populations, these normal values are higher in younger children. So of course, with the low serum phosphorus, renal phosphorus resorption should be high. So if it's not, in other words, if there's a low TRP and low TMP over GFR, that is consistent with rickets with a renal etiology. This is expected to be FGF23 mediated. This certainly can be XLH. That would be the most common. We'll talk a little bit about TIO. We're not in this particular presentation going to talk about other FGF23 mediated disorders. This is one of my patients. You can see here the rachitic findings that are really classic for this disorder at the growth plates, where you can see here at the distal ulna and radius, as well as the proximal femur, where you can see cupping and fraying of the metaphyses. And here you can see this youngster with a standing film that demonstrates bowing of the lower extremity. So I'll turn it back over to Dr. Insomnia.
Okay, so we'll now turn to a consideration of XLH in adults, because it is very clear that some of the most debilitating complications of this disease occur in adults. And for far too long, it was assumed that this disease ended with epiphyseal closure. We now are quite aware that that's not the case. And that's been documented in several recent reviews that have highlighted the considerable musculoskeletal burden of disease in patients with this disease. And it is not simply restricted to the skeleton. Patients have chronic pain that impairs their quality of life significantly. And I would refer you to these 3 studies that highlight those findings. Just like in children, fractures are very frequent in adults with XLH. In a series of 232 patients, 44 self-reported at least one fracture, with the average age at first fracture being very young at age 26. And not surprisingly, these fractures occur in the long bones of the lower extremities because of osteomalacia, the mechanical quality of the cortical bone in the tubular bones of the weight-bearing lower extremity bones like the femur, tibia, fibula are all impaired, and that leads to fractures. And you see here that that's the sites, the lower extremities are where the fractures are most prevalent, and they include, importantly and devastating, insufficiency and sometimes through and through femoral neck fractures. Upper extremity fractures are somewhat less frequent, but still well documented. In addition to fracture, a particularly devastating and peculiar complication of this disease is enthesopathy, which is the calcification of ligaments and tendons that results in restricted mobility of joints. You can see here around the hip joint capsule these large bony excrescences, which are basically mineralization of ligaments that results in marked restriction of motion of the femur. You can also see this patient has a pseudofracture. Here's another tendinous calcification at the elbow. One of the earliest sites in which we see this is the Achilles tendon, where you can see these radiographic evidence of enthesopathy as early as 18 years of age. Dental disease begins in childhood, but continues throughout adulthood. We don't understand the mechanism. We know that the pulp chamber is increased in size in XLH as compared to normal. There is a blunting of the tooth root in some individuals. This leads, by some mechanism that we don't understand, to frequent apical abscesses that result in tooth loss. Many young adults have lost many of their teeth. Adults sometimes are completely edentulous. It has devastating implications for self-esteem in children and adolescents. It may relate to some laxity of the dental ligament. We don't really understand the mechanism. Another calcification that occurs is in the anterior and posterior longitudinal ligaments. These are really troublesome and difficult to detect without scanning MRs or CTs, which we don't routinely do. But when they occur, they cause chronic pain and can actually lead to compression of the cord. I had a patient who developed transient quadriplegia when he was thrown to the ocean floor in North Carolina by a big wave and had one of these calcifications pierce the cervical spine. Fortunately, he had a rapid decompression and recovered. Hearing loss is frequent in adults. They complain of tinnitus, buzzing, loss of hearing occurs in patients in their 40s and 50s particularly, gets progressively worse. Some patients have symptoms of Meniere's disease with dizziness and nausea accompanying it. Can be moderate or severe, and oftentimes in mid to later adult life, people require hearing aids. Tumor-induced osteomalacia is a rare syndrome, and I thought what I'd do is present a case that sort of highlights the difficulties in making this diagnosis. This is a 33-year-old woman training for a second marathon. She developed left foot and back pain, thought it was due to aggravation of a motor vehicle-related injury that occurred 10 years earlier. She saw an orthopedist who put her in a walking boot for 8 weeks. There was no improvement. This is a bone scan done at that time. Now, I'm not a nuclear medicine expert, but you can see that it's not just the left foot that's involved. It's both the left and the right foot, and it's not just the cuneiform bone. So right away, you know that this is not simply a mechanical fracture of one bone. I'm not sure why they didn't comment on the fact that her right foot lit up as well. Over the next 4 years, she saw a neurologist, endocrinologist, a pain specialist with worsening generalized musculoskeletal pain. She was given a variety of pain management therapies without improvement. When I saw her in 2018, she had difficulty rising from a chair. She had unstable gait. She required crutches to walk. Remember, this is a woman who was training for a marathon. She had left foot metatarsal compression tenderness, but no obvious deformity, right hip and iliac crest pain to palpation. Her serum calcium was normal. Her phosphate was low. Her PTH was normal. Her renal function was normal. Her renal phosphate threshold was markedly reduced at 1.3 milligrams per 100 mLs of GFR, with the lowest and lower limit being 2.5. Her 25D was low normal. I consider it normal. So that had nothing to do with this syndrome. And her 125, importantly, was low. As Jill pointed out, in hypophosphatemia, the 125 should be high. If it's not, you should be suspicious of either terrible tubulopathy or more likely FGF23 mediated disease. Her ALK-Phos was elevated, and that was not because of liver disease, because her bone-specific ALK-Phos was elevated. And consistent with all that, her FGF23 was elevated. The diagnosis here is clear from these biochemistries in this presentation. This is tumor-induced osteomalacia. These lesions express the somatostatin 2 receptors. They bind certain radionucleotides well, like octreotide, and this woman had a light bulb-like lesion light up in the soft tissue of her left thigh. So she underwent resection of this tumor. It's very important that you have wide surgical margins because this tumor can be locally invasive. The histology established a diagnosis of the most common type of histology associated with tumor-induced osteomalacia, which is phosphaturic mesenchymal tumor. Post-op day 4, her serum phosphate is normal at 2.9. Her 125 dihydroxyvitamin D is off the wall. The upper limit is 65. This is typically what you see with a surgical cure. When you release the inhibition of 125 production, the 125 goes off the wall. That's a good biochemical sign that you've gotten the tumor. 2 weeks post-op, her serum phosphate is stone cold normal. Her serum creatinine is normal. Her renal phosphate is normal. It took her a long time to get better. It took her about a year to completely heal her skeleton, but she eventually did and ran her 3rd marathon. So this is a paraneoplastic syndrome caused by overproduction of FGF23 by a tumor that has certain cellular features that are subtle, but allow for a pathologic diagnosis of phosphaturic mesenchymal tumor. Clinically, patients present with acquired hypophosphatemia, skeletal pain, pseudofractures, and weakness. They're often debilitated in adults. I'm talking now about presentation in adolescents and adults. Usually the diagnosis is missed for years, just like my patient. Not usually malignant, can be locally invasive, often very difficult to find, can be in the skull bones, sinuses, spine, long bones, sometimes in soft tissues. Newer imaging technologies have markedly improved tumor localization. At the NIH, where they've seen more of these patients than any of us, they are able to identify the tumor in 70 to 75% of the cases. The best technology is called the gallium dotatate PET CT scan. Again, it's because these tumors have the somatostatin type 2 receptor, and the dotatate scan takes advantage of that. It's more sensitive and specific than FDG PET or PET CT. But if you can't get access to dotatate PET, octreotide is a very good test. I should mention that, again, in these patients, weakness is a distinguishing feature. They are way more weak than a patient with XLH with the same level of hypophosphatemia. So you take a patient with XLH who has a serum phosphate of 1.6, you take my patient who has a serum phosphate of 1.6, my patient can walk. She's totally debilitated. The patient with XLH may complain of weakness, but is not that incapacitated. That's true because for some reason, when you acquire hypophosphatemia after being normal phosphatemic, you can't accommodate as well as you can if you're born with it. One other point to make is it's very clear when you see this in adults. It's somewhat less clear in children. I work with a pediatrician who sees these patients, and sometimes making the distinction between this and XLH is not so obvious. So this slide just contrasts the two disorders. In XLH, usually presenting in infancy and childhood, TIO typically in young adult life, but again, can occur in childhood. Typically a family history in XLH, typically not in TIO, can occur in both males and females. Slightly more frequently do you see XLH in females. The biochemistries, as we've seen, renal phosphate wasting, low 125, normal PTH, suppressed 125, high FGF23, similar. Children present with gait abnormalities, lower limb deformities, impaired growth. Adults have a short stature, bone pain. Again, dental abscesses, not usually seen in TIO. Profound weakness, skeletal pain, pseudofractures dominate the clinical presentation in TIO. So we'll now turn to treatment of both children and adults with both these syndromes. And Dr. Simmons is going to tell us about treatment for children.
So I think anytime we're thinking about treatment of any medical diagnosis, we always have to go back to what are the actual goals of the therapy. And in pediatrics, our goals are improvement in growth, physeal healing of the growing skeleton, and reduction of skeletal deformities. So historically, we've had what we generally term as conventional therapy. This required elemental phosphorus at doses of 20 to 40 mg per kg per day, given sometime between 3 and 5 times per day, so quite frequent. Calcitriol is also given with conventional therapy at 20 to 30 nanograms per kilogram per day in 2 to 3 divided doses. And in 2011, we were given this clinician's guide to X-linked hypophosphatemia written by my co-presenter, which I think has been really helpful for the last decade in terms of helping us to have information about how to treat and how to follow these patients with XLH, whether they be children or adults. But what we don't have, and what we'll talk about in a little bit later, are clear guidance and guidelines yet on what to do now that we have a new treatment. In terms of conventional therapy in pediatric XLH, we have no controlled trials. Complications include secondary hyperparathyroidism, hypercalcemia, and nephrocalcinosis. And compliance can be quite difficult, as you can imagine, giving a medication 3 to 5 times per day. And that medication that's phosphorus can cause GI side effects and can be unpalatable to many. We need to remember that normalization of serum phosphorus is not the goal. And certainly if we do achieve normalization of serum phosphorus, we're probably over-treating the patient, which put them at increased risk for these complications that are mentioned before. We can partially correct leg deformities, decrease the number of necessary surgeries, and improve adult height to some extent. And there has been at least one report that treatment beginning in infancy can optimize adult height, but certainly not normalize to the height prediction expected, perhaps for unaffected members of the family. Adjuvant therapies are important. This may include neurosurgical care, such as may be needed for cranial vault reconstructive if patients have craniosynostosis. Physical therapy can be important. Attainment of motor milestones is frequently delayed, so many of these children need physical therapy assistance. due to hypotonia and these long bone deformities. PT professionals may also be helpful for addressing mobility concerns, including durable medical equipment. Pain management may be necessary. Fortunately, we don't see this very commonly in pediatrics, aside from the need for ibuprofen, acetaminophen, et cetera, but certainly sometimes pain is more severe and requires more potent pain management. And orthopedic care can be quite an important component of this treatment plan. In terms of surgical correction for pediatric patients, we really only recommend it if medical management is unsuccessful, as is defined by continued pain, limitation of activity, and gait disturbances. There are no standardized surgical protocols. Most classically, we've used osteotomies, in which basically the surgeons cut the bone, then add or remove a wedge of the bone, depending upon the type of deformity, and then go in and realign the bone. You can see here in this X-ray where the realigned bone is fixed with pins, a rod, or a plate with screw combination. Typically, this does not occur until after growth has nearly ceased, but certainly there are times when we have to do this prior to growth cessation, which of course can further affect the height potential of a patient. More recently has become available a guided growth plate procedure called Hemi Epiphyseodysis. You can see here that this tension band, which is this figure 8 component, is placed laparoscopically on the side of the patient's leg. It doesn't involve any cutting of the bone. Where this tension band is then placed, the growth plate is on that side is held steady while the other side is allowed to grow. And this actually works quite nicely in the patients for whom it may be an option. But about 2 years ago, Sumab therapy became available for the treatment of Xlh. And Sumab is a fully human monoclonal antibody that directly inhibits FGF23. And so I just sort of put this diagram here again to remind you of the location at which FGF23 has its activity. And certainly the expectation, therefore, would be that Sumab would cause improvement at those areas. Sumab is given as a subcutaneous injection in children every 2 weeks, in adults after the age of 18, once every 4 weeks. In terms of the randomized trial in pediatrics, we looked at 52 patients who were randomized either to continuation of conventional therapy or they started Sumab therapy. Both groups did have a brief washout period and then were followed for up to 64 weeks in the trial. The primary outcomes were pharmacodynamics, including phosphorus and renal reabsorption levels, as well as alkaline phosphatase, but also important outcomes such as Rgic findings and limb deformity, growth, mobility measures, patient-reported outcomes, and of course, safety. What you can see here is that patients in the Sumab group did normalize their phosphorus quite early within the first 2 weeks of therapy and maintain that level at or around the lower limit of normal for phosphorus through the remainder of the trial. Importantly, there were no patients that became hyperphosphatemic during the trial. And of course, the patients with conventional therapy continued to have their phosphate levels below the lower limit of the normal range. Now, what I would say that we really care about is what's happening at the level of the skeleton. And what we're looking at here is what we call the Rgic score, which is essentially a measurement of rachitic findings in a patient compared to his or herself at baseline. And the way this is, therefore, is that at baseline, you would be scored a level of 0. If you worsen over time, that Rgic score would become more negative. And if you have improvement in your rachitic findings at the knees and wrists, then you would have an improvement or an increase in your Rgic score. And a level of +2 is considered substantial healing. And you can see that by week 40 and continuing to week 64, the Sumab group did have substantial healing compared to the conventional group. When looked specifically at the number of patients who were considered to be responders with that level of +2 or better, the Sumab group was 39 times more likely to be in that group than the conventional therapy group, with a 74% compared to 6.3% at week 40 and 86% versus 18% at week 64. Similar findings were in the lower limb deformity score. This is really just a level of the amount of bowing that was seen. And again, this showed improvement in the Sumab group compared to the conventional therapy group at both time periods. Patients in the burosumab group did grow better, so their Z-scores improved over time. And the amount that they could walk, the distance that they could walk as the percent predicted distance for age and sex improved over time in the burosumab group versus the conventional therapy group. In other words, these patients had evidence of improved mobility. In terms of safety, there are a number of adverse events that were noted during the trial. Of course, most of them are things we would typically see in patients who are in the pediatric population over the course of a trial that lasts over 1 year. But the key points to notify you about are injection site reactions did occur in 45% of the patients in the burosumab group. I can tell you that these tend to be transient, erythematous, slight, small areas at the level of the injection site. There were no patients who even missed a single dose due to injection site reaction, and no patients who dropped from the trial at all. And what I think we're still not quite sure about is tooth abscesses, which did statistically occur with an increased rate in the burosumab group compared to the conventional therapy group. Of course, we know this is part of the disease process itself, but that's something to call your attention to. And so how do we move forward now that we have a new therapy? And as I mentioned before, we don't have any current consensus guidelines on how to continue to follow these patients. Fortunately, in pediatrics, we do have objective criteria, so we can follow radiographs, looking at physeal healing, reduction of skeletal deformities. I personally think these should be obtained certainly at baseline when you first meet a patient, certainly additionally when you start therapy if there for some reason is a delay, several months after therapy is initiated, and then every 1 to 2 years during the growth period. We also need to follow growth. And we need to continue to look for the consequences of treatment of Xlh. And so from a laboratory standpoint, I follow intact parathyroid hormone, serum, phosphorus, and calcium, urine studies as listed here every 3 to 4 months, renal ultrasounds every 2 to 5 years. I do have physical therapy, do a good baseline evaluation, and continue them and follow up if that's necessary. But I think there's, things, and we'll talk a little bit more about this later, but what we don't know is if there's a waning effect in treatment with burosumab, whether there might perhaps ultimately be neutralizing antibodies. Those were not demonstrated in the studies, but I think that's still something that we're continuing to look to see if that happens to occur. So now I'll pass it over for more discussion on treatment in adults with Xlh.
So there is evidence that conventional therapy works in adults. I have had an opportunity a few years ago to talk to patients, adult patients, before they were treated with anything, and then were treated with conventional therapy, and they viewed it as miraculous. So although right now it is no longer probably the best therapy we have, it does have efficacy. We did an open label trial of calcitriol and phosphorus in symptomatic adults with X-linked hypophosphatemia a number of years ago. And in that trial, which was a 4-year open label trial, we showed that there was a significant improvement in the key histologic measures of osteomalacia, which are osteoid volume per total volume, osteoid volume per bone volume, and osteoid thickness. And these percentages represent the percent improvement as compared to pretreatment values. So on average, compared to a bone biopsy result before they began treatment, 4.5 years later, there was about a 50% reduction in this key histologic measure. And it was accompanied by a significant subjective improvement in pain because it wasn't double-blind or placebo-controlled. You have to take this with some caution, but patients reported that they did feel better on therapy. So it's not without efficacy in adults. We've done a series of studies looking at other endpoints. Just like in pediatrics, adherence is difficult. However, in patients who are able to tolerate this medication, it improves dental disease, although it doesn't completely prevent it. Unfortunately, it doesn't prevent hearing loss or enthesopathy. And in inexpert hands, it is frequently accompanied by complications, much like those that Jill reported in children, including severe secondary and even tertiary hyperparathyroidism and nephrocalcinosis. So because of this unmet need in treatment, burosumab was developed initially to look at its effects in symptomatic adults with Xlh. And this was a double-blind, randomized controlled trial in which 134 symptomatic adults who had to have a brief pain inventory score of at least 5 and had to have phosphates below 2 were randomized to either burosumab 1 milligram per kilogram every 4 weeks or placebo. And just like in children, patients randomized to active drug rapidly normalized their mid-dose phosphate. This is 2 weeks after each dose, and maintained that throughout this 48 weeks of the trial. The placebo group did not achieve that endpoint until they crossed over to active drug, and they rapidly improved to the normal range. Pain and stiffness were both adjudicated. One of the ones that was most significant was stiffness, which I think is a measure in part of the impaired muscle function in these patients. That did not improve in the placebo group. It did improve in the active treatment group. Again, when the placebo group crossed over, they showed a rapid improvement in stiffness, and there was a continued improvement in the active treatment arm. But the most significant finding, mirroring the improvement we saw in rickets, is the improvement in fractures and pseudofractures. All patients had total body skeletal surveys at the beginning of the trial that were adjudicated by 3 radiologists blinded to treatment assignment. And then they had serial follow-ups of those fractures that were identified at baseline to see what percentage healed. And in the first 24 weeks, 43% of the pseudofractures and fractures identified at baseline completely healed, as compared to only 7.7% in the placebo group, such that you were 17 times more likely to heal a fracture if you were receiving burosumab than not. And it's important to point out that all these patients had been previously treated with conventional therapy. What I find most striking is that after the placebo group crossed over to active drug, their rate of healing mirrored the rate of healing that you saw in the active treatment group in the first 24 weeks. And there's nothing that could explain this. There's no bias in trial design that explains this. This shows unequivocally the efficacy of this drug. The group that were on active drug continued to heal, such that at the end of the trial, 63% of the fractures identified at the beginning were completely healed, and 35% in the crossover group, which is very close to what was seen in the active treatment group in the first 24 weeks. And again, osteomalacia is the sine qua non. It's the histologic manifestation of this disease. Osteoid volume, again, in patients who had been previously treated, showed a marked improvement in osteoid volume and osteoid thickness. Osteoid surface did not improve as much. Mineralization lag time, which is a derived measurement from osteoid thickness, showed a marked improvement. This is the amount of time it takes to mineralize that provisional scaffolding, proteinaceous scaffolding called osteoid. Normally, it's about 20 to 30 days in young adults. In these adults, it was over 1,000 days. It improved to around 100. It did not normalize. The dotted line is normalized, but it markedly improved, meaning that they were beginning to mineralize all this unmineralized osteoid. So in the double-blind portion of the trial, AEs were balanced except for an increased incidence of hyperphosphatemia in a few patients and a trend toward more frequent complaints of restless legs. In the combined phase 3 trial, there was no increase in nephrocalcinosis or nephrolithiasis. Again, this is a 1-year trial. No increase in cardiac calcifications, no neutralizing antibodies to drug developed. Urinary calcium measured at the end of the dosing cycle was not elevated. However, I have seen mid-dosing hypercalciuria, and unquestionably restless legs can occur with this drug. So what do we do in terms of deciding about efficacy? Well, unfortunately, we don't have as clear-cut measures as Dr. Simmons has in terms of healing of rickets, but clearly patients who have insufficiency fractures, I believe, should be treated. Patients with significant musculoskeletal symptoms, weakness or bone pain, I think are candidates. Patients with biochemical evidence of bone disease, high bone-specific alkaline phosphatase, particularly in the setting of a very low serum phosphate, particularly if they don't have raging secondary hyperpara, is evidence of bad osteomalacia, and I think warrants treatment. Preoperative relief for planned orthopedic surgery. During the trial, patients who had orthopedic surgery clearly healed much more rapidly if they were getting burosumab. So how do we judge efficacy going forward? Well, fracture healing is one. Normalization of bone-specific alk phos is one measure that I use a lot. I generally follow peak values for PTH, phosphate, calcium, creatinine, and 24-hour urine calcium for the first 3 to 4 cycles to make sure there's not mid-dose hypercalciuria. If there is, particularly in the setting of patients who have stones or nephrocalcinosis, it makes me nervous, and I might consider using a thiazide to lower that. I'd like to see trough phosphate values close to or above the lower limit of normal. I follow renal ultrasound. I have not reduced the interval of treatment in patients who have a serum phosphate lower than target, as long as they're responding clinically, although some clinicians have started doing that. But I have increased the dose above 1 milligram per kilogram in patients who don't meet target and are not symptomatically improved. As Jill alluded to, I think we have never had a drug that an antibody that we've used from birth to age 90. And so we really need to know, is it safe to give an antibody all that time? Do patients develop a neutralizing antibody? Because some patients seem to have a waning of the effect. And I think we need an assay for that. So the drug has recently been approved for the treatment of tumor-induced osteomalacia. But it is not the first treatment. It is not the second treatment or the third treatment. Treatment 1 through 10 for TIO is complete surgical resection of the tumor, because that is curative. As I mentioned, you need wide surgical margins. Burosumab can be used preoperatively, as can calcitriol and phosphate, in patients who are so debilitated that they are poor surgical candidates. It can be used, as I'll show you, in patients who are not operative candidates. There are other therapies. Now, non-operative candidates are patients who have tumors that are not resectable or tumors that you can't find. You remember, about 25 to 30% of patients, you can't find the tumor. So burosumab is approved for the treatment of those individuals. Infigratinib is a FGF receptor blocker. It's quite toxic, but has been used in some patients with malignant TIO and shows some tumoricidal effects, although its side effects are pretty serious. Radiofrequency ablation has been used for tumors in inoperable sites like the femoral head in a young patient who doesn't want a hip replacement. Cryoablation has been used successfully in similar poorly accessible sites. In patients who have malignancy, as I just said, inflectinib has been used, and lutetium dotatate has been used. And finally, although these tumors are considered to be radioresistant, I've had some success in patients with tumors, for example, in the C-spine region, invading cervical vertebrae, where I've been able to have pretty good response in terms of lowering FGF23 levels. But as I just said, there are some patients where you can't find the tumor, inoperable, no other surgical or non-surgical approaches available. The burosumab has been shown to be effective. This was an open label trial of 14 patients with tumor-induced osteomalacia who had bone biopsies before and 1 year after therapy, but there was an open label extension out to 144 weeks. There was a titration phase in the first 12 weeks where they were titrated from 0.3 milligrams a kilogram up to as high as 2 milligrams per kilogram to achieve a phosphate at the mid-dosing interval below the lower limit of normal. And that primary endpoint was reached. TMP-GFR also improved with therapy in this group. And as I said, the principal endpoint was improvement in the osteomalacia and healing of fractures in these patients. Just like in XLH, there was a marked improvement in osteoid volume, osteoid thickness, not really a change in osteoid surface. We see this in XLH as well. But again, because the thickness is diminished, the mineralization lag time, how long it takes you to mineralize that bone, markedly improved. And again, like in XLH, there was a dramatic improvement in fracture healing. Just like in that trial, in this open label trial, the fractures and pseudofractures were adjudicated at baseline. And as you can see, if you look at the yellow bar, the number of completely healed fractures and pseudofractures increased progressively during the trial and into the open label extension. And this is just a radiograph showing the very typical fractures you see in the ribs in a patient with this disease that healed very nicely with burosumab. So this drug is approved for the treatment of rickets-associated X-linked hypophosphatemia in children over the age of 6. As I just mentioned, 6 months over, I just mentioned it was approved last year for TIO. The pediatric dosing is 0.8 milligrams per kilogram every 2 weeks with a minimum dose of 10 milligrams and a maximum dose of 90. The dose may be increased to 2 milligrams per kilogram to achieve normal serum phosphate. In adults, the beginning dose is 1 milligram per kilogram every 4 weeks to a maximum dose of 90 milligrams. In patients who have phosphates that are skirting the 2 range, I'll sometimes start at 0.5. In TIO, the starting dose is 0.5 every 4 weeks, can be increased up to 2 milligrams per kilogram, not to exceed 100 milligrams, and can be administered as frequently as every 2 weeks. So what are the treatment challenges and where do we go from here? I think Jill is going to help us look forward in terms of managing patients with XLH.
Okay, so in terms of the challenges in managing children with XLH, one of the common questions I get from families is, when can we stop therapy? As you can imagine, I actually just had this question yesterday with a young patient, a toddler who was a new mutation, and the family was quite devastated and really couldn't wrap their heads around the idea that this was something we were going to start at this young age and perhaps have to continue for the remainder of this child's life. And I had to answer honestly that I'm not sure we know that particular answer. Do children, as their growth plates close, actually warrant some sort of treatment cessation or a pause of treatment? We don't know that. What we also don't know is really, when should we be changing to adult dosing? So certainly here in the United States, it's labeled by the FDA to be used as every 2-week dosing up until you're 18 years of age. And after you're 18, it changes to, sort of what we consider to be traditional adult dosing. In part, that's because that's a population that hasn't been studied. The 12 to 18-year-olds have not been involved in any of these trials. And I think we don't really know whether these children who become in the middle part of adolescence and have closed growth plates really need to continue the every 2-week therapy. Fortunately, we'll continue to get some of these answers. There's a 10-year international disease monitoring program underway that is evaluating patients, or that's including patients regardless of treatment status, which I think will help us to understand some of these questions. I think the other thing that we really need to consider is the importance of transition of care to an adult provider. Historically, I think many of these patients, as soon as their growth plates closed, we stopped treating them. They left pediatric care and often didn't enter back into adult care until perhaps they were having some of these abnormalities and substantial pain and other things that's been discussed by Carl. And so I think we need to not let that happen. We need to make sure we're handing off care to an adult provider who's knowledgeable about XLH, who can continue to talk to these patients about whether or not treatment needs to be restarted, continued, what this means for their own children, et cetera.
So as I alluded to at the beginning of this presentation, the socioeconomic impact of XLH is going to remain substantial for the foreseeable future. Enthesopathy will continue to be a major problem for many middle-aged and older individuals with XLH. Dental disease is likely to persist in adults. Hearing loss will not be restored in those who have lost it. And difficulty with ambulation will persist. Surgery for joint disease and spinal disease will still be required. So what do we need to do to try to address these issues? Well, we need to more precisely quantify the impact of XLH on the emotional development of children and its impact on self-esteem. As I sort of alluded to, this disease really has terrible impacts on children during the period of time where they're developing their own sense of self. We need a prospective trial of the spinal ligament calcifications, which are asymptomatic until advanced disease presents. We need to better understand dental disease. We need to better understand hearing loss and tinnitus, including a prospective study to see whether burosumab prevents it. We need more consistent multimodal approach to pain management. So many of my patients have been on narcotics for years, and I think it's very important that we try to have a much more nuanced approach to pain management in them. We need to clarify, as Jill alluded to, the role of burosumab in treating adults with XLH, and should there be a drug holiday in early adulthood? I think I have my own opinion about that, but I think we need data. And we need to develop and engage patient advocacy groups in other parts of the world besides the US and Western Europe. Thank you for attending this presentation. We're now going to turn to the question and answer session. Jill, perhaps while we're waiting for folks to collect their thoughts and ask us some questions, I was wondering if you could tell us what your post-marketing experience has been with the drug, and in particular, have you run into any concerning side effects, and have patients been pretty accepting of the drug? And how many patients do you have that the family is self-administering now?
Great questions. I will tell you that the majority of my patients actually have parents who are self-administering. Most of them started with home health nurses coming to their home and ultimately decided that was pretty intrusive in their daily lives. And so after just a few months of that, they have almost all transitioned to giving it themselves. Of course, we have to keep a reminder that at least here in the United States, the approval was to be given by healthcare providers. So that is still how it's labeled. But truth be told, most of my patients are giving it at home. I found patients to actually be very tolerant. I've had really no sufficient side effects. Patients have had really maybe occasionally very transient erythema that lasts for 30 minutes at most. And I've had some good responses, both in the serum values of phosphate and the improvements in alkaline phosphatase, and of course, most importantly, the improvements in the skeletal findings that we see on x-rays. I have one patient in particular whose bowing has not improved and really had very substantial bowing. And so that's been something that the family's been really worried about, that perhaps it's, a patient with limited effectiveness. But even that particular child, the rest of the markers are improved. And I think he's running and playing and seems to be feeling better from a motor skill standpoint. So I think, there's still going to be some limitations in what we can do for some of these patients who are really severely affected prior to being started.
And as you mentioned, one of the things that was surprising in the pediatric comparative trial was this issue of apparent increase in dental disease. Have you seen anything in your practice that raises that as a concern?
I think it's hard to say because all of my experience is going to be anecdotal. I've certainly had some patients who had dental abscesses. I believe without exception, all of them were patients who were having abscesses before being started on the medication when they were on conventional therapy. So I think it's still unclear whether this medication truly does increase the frequency with which patients have dental abscesses. I'll ask you the same. What are you experiencing in the adult patients?
I've not seen anybody complain of worsening of their dental disease. I've had a few patients say that their dental disease has been quiescent since starting it, which surprises me, frankly, because much of the structural abnormalities are not going to change unless it's possible that there's better mineralization at the insertion of the dental ligament, because I think that, as I said, I think that may play a role.
Mm-hmm.
Yeah. Have you had any patients where the biochemistries you said you had this one patient where you were wondering about the efficacy. I think that's one of the things that we're all hoping we're not going to deal with, is a fading of efficacy because of neutralizing antibodies. But you've not seen that yourself.
I haven't seen it in any of my pediatric patients. I have one young adult who has had some increase in pain and certainly a serum phosphorus that was quite low, in spite of being on what is thought to be the appropriate dose. And I think what I'm starting to wonder, and what I'm hearing from others, is that perhaps even some of the adults may need more frequent therapy than every 4 weeks. That's a somewhat arbitrary decision, I think, when the trials were started. And so whether there may be patients who need either increasing dose or perhaps increasing frequency, I think may be more where I would start, other than thinking that it's neutralizing antibodies.
There's a question for you, Jill. This comes from Hamilton Casanelli, I guess. Hi, Dr. Simmons. Do you think that probably the serum phosphate level should be 4 or more in patients treated with burosumab in order to achieve better results in bone? Because in the normal pediatric population, we never see phosphates less than 4.
I think that's a really great question. I think we knew, of course, with conventional therapy, as I mentioned in the talk, that pushing the phosphate levels too high caused some increase in the side effects of therapy. I think I have less concern about that, obviously, with this particular therapy, and we may want to consider pushing those levels slightly higher. I think meaning to your point, within the normal range for their age, I think we should be probably a little bit less conservative about that and more aggressive. But truthfully, without things like biopsy results, we don't really know the answer. I think it makes sense that physiologically we need normal serum phosphate and normal serum calcium to appropriately mineralize bone.
Yeah, I mean, the other thing that's peculiar, of course, is that there's no compelling dose response between the drug and the effect, which is one of the things that's perplexing. We're giving a drug in milligram quantities to neutralize a hormone that circulates in picogram quantities. So, you know, the reason that we're not completely wiping out all of FGF23 in the serum is because very shrewdly, the manufacturers chose an antibody that didn't have the absolute highest affinity for the ligand for FGF23. So they chose one that was modestly effective. And so there isn't, you know, the strict linear dose response between drug dose and changes in phosphate, which is peculiar and also, I think, makes it difficult to know necessarily whether you bump up the dose, you're going to get a higher effect, biochemical effect.
That makes sense.
Here's a question. Someone was asking about fertility in these patients. Well, we have had in the trial, all participants were expected to use 2 forms of contraception. But despite that, there was at least 1 or possibly 2 patients who conceived during the trial. And post-marketing, not surprisingly, I've had 2 patients get pregnant. Both of them were obviously instructed not to get pregnant while taking the drug. And both of them, we stopped the drug immediately. Both of them had full-term normal deliveries. So a priori, it's not obvious that there would be an adverse effect, but I don't think we know right now. Here's a question, I guess, for both of us. I'll take this one because the next one's for you, Jill. Is increasing the level of serum ALK-Phos after initiation of therapy a marker of healing of pseudofractures? I think so. I think so. There's some weird things with serum markers like CTX and P1NP that are off the wall in these patients. We don't really understand it. But the bump in ALK-Phos, I think, is a reflection of the initiation of mineralization, which clearly is going on beyond that initial rise. So I kind of view it as the initial recruitment or initial activation of osteoblasts. And yeah, I think it's a good indicator, a biochemical marker of drug action. Dr. Simmons, this comes from Dr. Alvaro. Dr. Simmons, we know that Burosumab patient, the Burosumab starting dose in children is 0.8 milligrams per kilogram a couple of years ago. European PI stated to start at 0.4 milligrams in children. European PI has been updated to 0.8 milligrams starting dose in children, but I still see physicians who insist that starting at 0.4 due to the fact that clinical practice recommendations, I guess, vary. So the question, I guess, comes down to 0.8 or 0.4 as the starting dose.
I don't think we know that answer very well. Maybe to the point of the question or the answer that Carl said just a few minutes ago. Yes, you're absolutely right. In Europe, the initial approval was to start at 0.4 and to titrate, I believe, based on phosphate levels until they were within the normal range. And but we don't have a comparator group. We didn't compare 0.4 versus 0.8 in any trial, so I can't tell you for sure. I know that, you know, we know that 0.8 was the dose that worked in our pediatric trials, and we actually had to increase some patients up. And some of the patients that I had in the original trial, one in particular, we did have to increase, and that patient did have clinical improvement on an increasing dose. And so I think you always have to just consider the individual patients. I think conversely, there's some case series, if you will, about the patients with 3' UTR mutations that may not need as high a dose. And a matter of fact, they may have some serum hyperphosphatemia when started on a dose of 0.8 mg per kg. And so in those children, and again, this is not well published yet, this is not even well understood, but certainly in those children, I do often start with 0.4 mg per kg, and I have seen clinical improvement on those lower doses.
Yep. Thanks, everyone. Thanks for listening, and thanks for your questions. They were all very helpful and informative, I hope.
Yes, thank you very much.